This is an unfortunate event, but of course, IHD team already had in place a replacement moderator, and Mats is also connected to the foundation and the creation of IHD. Mats is a renowned expert in health data strategy for industry and academia. Following a 12-year tenure as a global integration lead for electronic health records services at AstraZeneca, Mats' new portfolio encompasses the roles of Executive Strategic Advisor for Ignite Data, developer of a system-agnostic AHR to EDC solution for clinical trials, is a Senior Industry Scientific Director for the IHD, the European Institute for Innovation Through Health Data, and is a board member of the new Center of Health Governance at the University of Gothenburg. Matt, the floor is all yours. And I was told that it's going to be strict with timing.
Right. So thank you. Is this on? Yeah, I'm audible.
You are audible in your life, and the floor is yours.
Right. So thank you very much, Paul. It's a privilege and an honor to step in for Dipak in his big shows, but I will do my best. So welcome to this second plenary session of the conference. So I am the moderator, and we have a very nice setup of speakers. So we will start with Markus Kalliola, Project Director for Sitra, followed by Ricardo, Jardim, Gonçalves, and full professional of international development and UNINOVA, and ending up with Yiannos, Tolias, legal lead on AI and AI liability in healthcare, Director General for Health and Food Safety, European Commission. And the excitement topic of today is actually what are the new topics regarding data quality. So these three renowned speakers is going to provide three different exciting perspectives. As a moderator, I will give each speaker 22 minutes, and I will give you a nod after 20 minutes. To secure that, no doubt, it will be a number of important questions to your excellent presentations. So we have a very nice 90 minutes keynote presentation, and I will tease you after this presentation, there will be a very nice coffee break outside in the same place where we had the excellent lunch. So that is also something that we can look forward to. So with that, I would like to give Markus Kalliola, the floor is yours.
Well, thank you. So I'm also privileged to be here today. My name is Markus Kalliola. I work for the Finnish Innovation Fund, which is an organization under the Parliament of Finland, and is working in multiple fields of the society, including democracy, including people's participation. I think you cannot hear me. Is it so?
The microphone.
The microphone's not on.
No.
Miguel, atenção, o microfone aqui do palanque não está a funcionar. Okay.
Can you hear me now?
I think Zoom participants are listening to you, Markus. Unfortunately, on-site participants have not the blessing of your voice in the loudspeaker, but they can listen to you in presence, of course.
All right. Well, so
now
it's better. Now. So I was explaining that I come from the Finnish Innovation Fund, which is an organization under the Parliament of Finland, which aims to renew the Finnish society. At the moment, we are doing that in three fields: democracy, sustainability solution, and data. So my work is related to the health data. Prior to working to the Finnish Innovation Fund, I worked in the European Commission in DG Sante. So for the health and food safety, was responsible of the IT project in cross-border healthcare. So that is where I come from. Very privileged to speak about the European health data space today, because I think it is really a landmark. It's a game changer for the European Union and how we manage with health data in many ways. Today you will hear from me, but you will also hear from Yiannos, which works for the European Commission. After that, there's a separate section for the European health data space, where you will also have a very good presentation. So there might be some repetitions today, but I think they all build on each other, and it's also a good opportunity to learn more about this topic. Why I'm actually speaking here today for you is that I'm coordinating the joint action towards European health data space, also known as TEHDAS. So that's the first part of my presentation. The second part, it's about European health data space, and in my opinion, the most important topics regarding data quality in that. And finally, I will share with you 3 very personal opinions or takes on data quality that I made up yesterday when I was in an airplane waiting for the plane to start, and it was delayed by 2 hours. So you will get some new inspirations from that. The joint actions are a financial instrument from the European Commission. In the 3rd health program, this project was initiated. It is a financial mechanism that includes European Commission funding or the health program funding and the member states both paying part of the project. This initiative was started to support the member state and the Commission in promoting concept and sharing data on the secondary use. So it's very focused on the secondary use of health data. 25 countries decided to join. Most of those are EU countries, but in the 3rd health program, also UK, Norway, Serbia, and Moldova participated. We started on February 21, and we will finish our work next summer. So the coordinator is the Finnish Innovation Fund on this matter. Our work is distributed in work packages, as it usually is in the European projects. So each of these work packets is managed by a different country. The data quality work package leader is sitting here on the 2nd floor, Enric, and Enrique will speak in the second session after this plenary. So in the governance part, we have concentrated on the issues. Why should health be regulated separately from other sectors? So why we made a case about the specificity of health data. We also compared different health data governance mechanisms that are functioning at the moment in EU, for example, e-health networks, EMA, ECDC, Eurostat, and so on. And we concluded that none of those have the mandate or the capabilities at the moment to govern the health data space as it should be governed. So we proposed something new. Well, we all know now from the legal proposal from the May this year that the Commission established a new board for governing the European health data space. We will provide our final conclusions on the governance issue in a few coming months. On the data quality, Enrique's team has been working very full speed, providing already very good deliverables on the data quality. Some of those which has been built upon by the European Medical Agency. You heard today on another speech that they are building their data quality framework on top of the one that we have published from the TEHDAS joint action. And our final outcomes will be delivered next spring. So if you want to follow up that activity, it's good also to join the next session on the European health data space and hear in more detail about that. On the infrastructure side, last year we published our view on how the infrastructure should be built for the European health data space. And the proposal that was given on May this year was quite similar to what we proposed. Of course, it was also developed hand in hand with the experts from the Commission and the member state and stakeholders. So a lot of views were heard. That work is also led by the IAX Institute from Spain. So a lot of activity actually building the European health data space coming from Spain at the moment. But we haven't forgot the citizens either. So we have a lot of activity on citizen engagement. We made a survey for more than 3,000 people last spring about how they view their health data use and how we could build trust in the European health data space. We have focused on the data altruism, and we have focused on the sustainability. So how to make this European health database also financially sustainable in the future. So those are the topics that we work on. I will not go in detail on all the contents because they are out there. We publish everything we do, and you can find it on the online www.tehdas.eu. So there it is. Everything will be published. All the documents are there. And especially as this session is focused on data quality, the next session, as I've already said many times, we'll be focusing on TEHDAS work there. What about the European health data space then? I said that it's a game changer. I really believe it. in everything that there is, I think it's really pushing the European countries, the member states further, but also the data controllers, the hospitals, all the stakeholders that are involved further in data use. I heard today that it's very difficult to understand the European data space regulation. Somebody said it in earlier sessions. I must disagree. I think if you want to kind of like take the high level view, it's quite easy to understand, in my opinion. In chapter 2, you have the primary use. So what rights do the citizens have for their health data, and how it can be used when they travel cross-border to other countries, how it could be used for their care, or if you forgot your medication back home, you can walk into the pharmacy in your destination country and get the medication with your prescription that was made for you back home. So quite simple and easy to understand ways of us citizens, how we can benefit from the health data. Chapter 3 is about the conformity of the EHR systems and wellness applications and building a single market in EU. The chapter 4 is the main beef of today, in my opinion, regarding data quality. It's about the secondary use. How do we use health data in the EU for research, for innovations, for statistics, for teaching, all the purposes that are listed in the chapter 4 for the health data use. The proposal really is a game changer, especially on this field, because there hasn't been an EU legislation for this or much of a harmonized way of accessing the data in the secondaries before. There's so many different interpretations of the GDPR, so many different ways of accessing data. In some countries, it's specific to the data controller or larger area. In some countries, we have national systems, national processes. In the chapter 4, it introduces a harmonized way for the whole European Union. And I think that's very interesting. And then you have the governance side and some other things. But I think in these very simple means, I mean, the European Health Data Space proposal can be understood. But of course, you can dig in really deep and understand it in full detail. You need to spend a bit of a time. I said that the chapter 4 will introduce a new mechanisms to access the health data and the secondary use purposes. This slide from the European Commission explains it in some key terms. In data joint action, we use a bit different terms because, of course, we didn't know what the European Commission is going to use. We called these access points nodes in our architecture picture. The European Health Data Space uses the word health data access bodies. In each country, there will be one or more, and they will give permissions for the use of health data in the secondary use purposes. The data comes from the data holders, so you can see them listed there, different kind of data holders, depending on the data, of course. And then you have the data users who will end up using the data in the secondary purposes. The usage will take place in what's called secure processing environment, the SPE, as you can see on the screen. So I promise that I will tell what's, in my opinion, the most important parts regarding data quality in the proposal, because that is the main discussion points for today. If you go to the chapter 4, the section 5, then from there you find the main data quality elements. There are Article 55 and the Article 56. So Article 55, if you think about the FAIR principles, it's mainly concentrates on the F part, so findability. Each data holder, whenever you have health data that is usable in a European health data space, you need to describe the data sets that you have. The source, the scope, the main characteristic, the nature of the electronic health data, and the conditions for making the health data available. So you have this data, and then you have the health data access body that collects all these data set descriptions. And then you have European Commission creating a catalog of all the member states. So finally, you will be able to see what data is available in the whole European Union. I think that is, if you think the situation as it is today, of course, you have none of that. So it will be a huge benefit for the data users. But how do you trust the data? How do you know that the data that is out there that is described is fit for purpose for your needs? There comes the data quality and utility label. So it evaluates the data it tells it whether it's good quality, whether it's not that good, maybe even a bit less quality data is fit for some purposes. It gives the technical quality, the completeness, the uniqueness, accuracy, validity, timeliness, and so on. The coverage of that data set. So whose data is it, how long it has been collected, and so on, and the metadata of the data. I think it's a very important part of the data quality to have these assessments, have this label, to understand and to be able to trust the data. But I think there's one hidden gem in the proposal that it's not that much discussed when we talk about data quality. So that is my next slide, a hidden gem in the European health data space regarding the data quality. And I call this virtual cycle of data quality improvement. Now, when the data is used by the data user, they can enrich the data. I mean, you do your study, you find problems with your data, and you correct it. Now, the proposal says that you need to give back that data to the health data access body. Now, the health data access body then has the duty to send it back to the data holder, which then needs to take into account those changes if it's feasible, thus creating that the data gets improved by each study that is done. Now, that might not seem that remarkable for you, but consider that happening in each data holder in EU, in each study that is being performed, time after time, data getting better. I just heard today on another session, I think it was, I don't know what was the name of the company that presented, but they said that when they started using, they had this. Mats, it was the company that was in the same session regarding the fire implementation. And when the data was used, they said to the data holder that there was some missing data from the integration, and they went back to find out that actually the data was inputted wrongly to the fire interface. So you can consider this happening in the European health data space, actually fixing the problems at the source, because the problems are found out later in the study. So this kind of continuous improvement loop could take place in the European health data space, and finally really improving the data quality in the long run. So I think these three combines, of course, are, in my opinion, the main points from the data quality perspective. So I promised you at the end of my presentation 3 personal takes on data quality that are not that technical or that detailed that was the articles from the proposal. The first statement that I make, that data quality is expensive, or this is the statement that I hear a lot of times, people saying that it's very expensive to do quality data. And the notion is very real in our society. Quality always costs. You buy some clothes that are good quality, they are always more expensive than the bad quality. But I would like to make a statement that in health data, this is not the case. Bad quality data is expensive. I think if I heard, I mean this today, but I have heard it before even, that for example, the waiting lists of patients in healthcare are causing millions of costs for the healthcare sector. Is bad for the patient. They might be double referrals in a waiting list, or they might be wrong referrals in a waiting lists, or so on. And this is just one example that the bad data quality is causing problems in the healthcare sector. I heard that in UK alone, they spent millions of pounds fixing the data in those waiting lists, and if you had the better data quality in the beginning, you would actually save money. So that's my first statement on data quality. That is actually the bad data that is more expensive. Then I hear the thing sometimes the people say, like, if you had better data, then we would do this. We would do miracles with the data if it had it better. We would build AI systems, we would do that, but we cannot do it because of the bad data quality. My statement today is that miracles don't exist. So use the data that you have. Start building on the thing that you have, whether it's the local data, whether you are in a hospital, whether you are in a regional level or in a national level. You have heard so many times that when you use the data, the quality gets better. You find the problems in the data when you use it. So don't wait it to get better, or don't fix it the data so that you can use it. Use it now and fix it as you go. Now, this is probably the hardest one to kill. We need incentives to improve data quality at the source. And I have heard this probably most times than anything else, that the reason why the data quality is good, that we don't have incentives at the source, especially on the people that are providing healthcare. And we sometimes think that healthcare professionals as donkeys, and we put a carrot in front of them and say, well, if run faster. These are the most trained professionals in all our society. And we think that if we just tell them that the health data quality is important, they will do something differently. Or if we explain it better.
Get ready to supercharge your live streaming experience with Restream Studio. Absolutely everything you
That's
need
not
to
part
run
of
a
my
successful
presentation, but was that the 2 minutes mark?
Yes, absolutely.
Yeah, I know. I'm running out of time. So this is the hardest one to kill, but I think producing data quality should be easy and seamless. I think these professionals know that it's important. The problem is that we give them the impossible mission. We give them user interfaces that are so difficult to use that the data quality is impossible to produce. And the big problem behind this is that the greatest mind of our society are working in getting the Facebook advertisement 1% more effective, or making the Google search 0.001% second faster. So if you get people that are capable of doing user interfaces, doing better systems for the healthcare to work in this field, I think this should be easy to fix. And I think we should pay more attention on making the quality data easy and seamless, rather than trying to make the people working in lousy systems to make work a bit more on that. So those were my 3 statements that I made that yesterday. I hope you enjoyed. So thanks for the presentation. I'm looking forward for the questions.
Yes, we have first of all, thank you, Markus, and you are ahead of time. Excellent. So we have Nigel.
Thank you very much for your perspective. So Nigel Hughes from the EuropeanCommission. I have to say, I think particularly towards the end of your presentation, I wish we could share your We've modeled a decade of experience. It would be that easy, we've done it already. Data quality is not easy at all. And it's, one thing I agree with you about is that we shouldn't be enforcing some healthcare workers who are trying to save lives. If I'm touched with, if I leave the venue and I get run over, taken to trauma unit, they're going to spend the golden hour trying to resuscitate it. They're probably not thinking they need to keep the records completely research grade quality and so forth. And I wouldn't want them to at the time because I'd like to stay alive. So I agree with you in that sense. But actually, within the legislation, for instance, you have competition. You say we should have a better system. Absolutely agree with you. We don't have fit for purpose data capture system, VHR. And then why is it the HDX legislation? You have self-certification, whereas the draft that came out before this version was enforced certification. A self-certification that you lose the stick, maybe the carrot, but prevent it, not necessarily help professionals. So there are lots of inconsistencies in legislation, but this is a massive thing. And actually, you're talking about a small microcosm of how we use data in terms of this idea of data being provided and then returned and so on. That's a fraction of how we work with data. And it doesn't always improve the quality of data either. There are things you can fix, like it's poorly coded or programmed the wrong way, or there are 5-6% of pregnant men in the database. But, and that's a truism, But actually, most of the other things are intrinsically challenging at the source when they're recorded. And you can't replace a missing data, for instance. So I think, to be honest with you, I think you need to think hard about how complicated this is in the real world, and think about some of the messages that you're presenting. Because actually, I think for many, that's really, it's a bit naive and very, very challenging. Actually, I don't think it's appropriate.
Yeah, thanks. I think there was no question, but a comment more.
Okay.
There was no question, but a comment.
No, it's a comment. So, yeah, I think I had to make it. I think that was appropriate.
Yes.
Yeah, it's probably a comment again in this in two parts. The first is the sheer technical challenge of doing what Article 37 suggests. And also, it's kind of, you say on the one hand that you don't want healthcare professionals to be overburdened, but then you want us to give them back data and tell them what's wrong with them. So, even if you did that in very simple terms, even if you took exactly the same data set you presented with all its features and attributes and observations, and you gave them back exactly the same data set with features, attributes and observations, that could be a huge data set. And we could say, look, here are all the problems, here are all the things, color the data, whatever. They then have to go through an exercise in doing something with them. So that in of itself drives a lot of churn. Okay. The other thing is the sheer impracticability of most AI systems. Most AI systems don't use the data that's provided in its raw form. It's pre-processed, or it's enriched, or it's converted somehow, some way to make it useful for the modeling technique that you're going to use with vision systems and convolutional neural networks, semantics, and large language models, whatever direction we go in. So, and the second point, and this probably gets to the heart of it, and maybe this will drive another debate later in the 2 days, but most of my challenges with colleagues in industry, particularly regulatory compliance colleagues, is that data quality is a population conversation at its heart. Talking about individual data errors and individual data points is a data integrity conversation. They are two different regulatory discussions. They are not the same thing. Now, unless, there are situations, person-centered medicine, personalized medicine, of course, you can get them down to individual observations because it's a single person. But generally, you're talking about populations in terms of data quality. And it's also a weighted conversation with limitations and constraints. So even if you give, and I'm very fluid about all the categories that are used for data quality because, being fluent in the English language, I know how flexible English is, right? And 3 words can mean the same thing. So I'm very careful not to get into that. But whether you have 5 categories or 10 categories, they have weightings, and they also, because everything needs context. You can't say that these all apply at every single clinical trial or every single modeling application or every single analytical discussion. And there are also limitations and constraints. I'll give you an example.
I think probably you're speaking too long for the next presentations to start, but we have a coffee break after this, so we could perhaps continue there. I think you have very good points, both of you, so happy to discuss further. And you should really go to the session of the European Health Data Space to continue this good discussion.
Unfortunately, I'm talking in another.
Sorry for that.
Well, I'll catch up.
Yeah.
All right. Thank you very much, Markus. So the next speaker is Ricardo. Who is yours? Right. The director of UNINOVA.
Yeah. Okay. Good morning, everybody. It's a big privilege to be here. I would like to say that indeed to be a premium supporter for this event is really very, very relevant. This is not my presentation, is yours? Okay, you can swap because that's fine. You can
No, I think we All right, okay.
So you can.
Right, so we do a very swift switch. So Yiannos, Tolias, the floor is yours. and now
Switch it, please.
Okay. Yes, that's mine. Thanks a lot for the invitation to this exciting event. And at the beginning, also our best wishes to Dipak for a quick recovery. Today we'll talk about AI and data, and also what I call there the EC responses. Of course, just to mention that I'm also injecting issues or from my research findings, personal opinions, personal interpretations. So just a little disclaimer there that what I say is not necessarily representing the official position of the European Commission, because I can speak more also about my research and other stuff there. So I will talk about, when I say EC legislative responses, I will mainly connect AI and data to the AI Act, which was published in April 2021, the European Health Data Space, May 22, the Product Liability Directive, September 22, and the AI Liability Directive, September 22. These are all now negotiated. They have passed the Commission level, they have been published, and now they are all negotiated at the Council and at the European Parliament. So it's they are not yet adopted, but at that stage of negotiation now. So as we all know, the abundance of health data plus the advancements in AI have created the potential to transform healthcare. However, at the same time, we see some new concerns, and I call them new concerns because we have not seen this type of concerns, or maybe not so vividly, when we're dealing, let's say, with, let's call them conventional medical devices, non-AI based medical devices. So we usually see them with an AI-based medical device, an AI-based system. And of course, these concerns, they lead to lack of trust, lack of uptake, lack of upscale. And these concerns, I'm sure you have all heard most of them, if not all of them. They are concerns like questions on the protection and security in the collection, transfer, and use of health data, questions on performance of AI systems. If an AI system was developed and tested in Tokyo, does it equally work well in Europe? The questions on physicians or clinicians, AI interactions, how they should be interacting in clinical practice, and how what happens in real deployment of AI systems, ethics and morality, bias and fairness, transparency, explainability, and liability. See, these are kind of the main, let's say, headings, or some of the main headings that of the new concerns. Now, why, at this point, I would like, before I go into the EU legislation or proposals, I will take one step backwards and see what are the root causes possibly for these concerns. This comes actually from my research, and there is a paper at New York University's Jean Monnet working papers. You can find it there, actually, the more details of what I'm arguing. But the gist is this, at least the first part, one of the gist of the first part, it's this. Possibly one of the root causes for these concerns is what I call the systems intelligence. And what I mean by the systems intelligence is that the systems, they are performing their tasks close to humans. In humans, we have, for example, a type of reasoning, which we'll call inductive reasoning, that we are performing a lot of our, what we call clever tasks, and what actually defines intelligence and human intelligence. Some animals, they have the same type of reasoning and the same type of intelligence in conducting their tasks. The same kind of idea, we see it also in these systems. First, they can learn from data. And secondly, they can generalize. Generalization, I'm sure most of you or all of you know, is the ability of the system to generalize, to apply its knowledge on new cases it has never seen before, and be able quite accurately to predict what, for example, the system is looking at. For example, I've never came to Porto to look at this thing here, but I can predict this is, for example, an auditorium. That's a bit the idea. And the ability of the systems, and this is, of course, in contrast with, let's say, let's call it conventional MRI, which basically produces a physical measurement of measuring, for example, signals generated by protons and creates that image. The AI system interprets the image and makes inferences of the latent causes of what it sees. That's a bit the qualitative thing, and as I said, you can read more in my paper. This ability now allows them to penetrate into a domain that it used to be reserved for human intelligence. And in the area of medicine, performing the tasks, the classic tasks of a physician, basically diagnosis, prognosis too, diagnosis, management of the patient, and treatment of the patient, the classic tasks of a physician. So they can now enter into this domain. Let's see now how the AI Act addresses some of these challenges. For example, with assuring a good generalization ability, the AI Act has a different provisions there, among them risk management system, data and data governance, which I will come back to it since we are talking about data. There is a section on accuracy, robustness, and cybersecurity. There is another section on human oversight in relation to designing of the algorithm, another section on transparency in relation to designing of the algorithm, corrective actions and withdrawal after you deploy the algorithm in real practice. And let me come to the data and data governance, which is Article 10 of the AI Act. One of them, actually paragraph 4, says that the training, validation, and testing data shall take into account the geographical, behavioral, or functional setting in which the system is intended to be used. So at this stage, I think you may have two questions. First, what is the meaning of the data set, should take into account the geographical, behavioral, and functional setting? You may say it's a high-level requirement. What does it exactly mean in real practice when I am developing an AI system? The answer to that is that it is indeed a high-level requirement. That's how actually EU law is drafted at this stage, at the first stage, because this is what we call essential requirements. So you draft the objectives, the high-level requirements, and normally this is what actually the Commission is also thinking now, of issuing a standardization request, which basically it will transform these essential requirements into specific standards to give some more concrete meaning as to how you could be fulfilling your obligations under the AI Act. And also, except the standards, there is also a provision in the AI Act, which is that the Commission could also adopt common specifications in addition or instead of the standards. So that's how this would become more concrete, but that's at least the objective there. The second question you may have is that, okay, the AI Act imposes its obligation, but if I'm a small startup, where do I find the data to really fulfill my requirements under, if we come up to say the geographical, behavioral, function, it means A, B, C, D, E, I just don't have the data. Or sometimes I cannot get the consent of the people to give me their data. I wish I could have their consent, but they just don't give it to me. Hence, I cannot really fulfill my obligations in that sense. Here, I think, is where I will jump to the European Health Data Space. Actually, Markus has shown the same slide, but maybe I will talk differently about this slide. So I think this is where the European Health Data Space could come, which first, it follows a different legal base of collecting data, which is not consent. So the consent of the people is not required to be collecting the data Of course, it provides security mechanism because these data which are collected without their consent, they have to be used only for certain specific purposes and prohibited for others. For example, you cannot use their data to change their insurance premiums and so on. But you are allowed, for example, it says specifically there, since we're talking about AI, to use it for testing, validation, and training of AI algorithms. So it has a clear purpose there. Then, if you're a data user and you want to use them for these purposes, you make a data application to the health data access body, say, this is who I am, I want to use them for training my algorithm, also fulfilling my obligations under the AI Act, just to make you a bit the story and the narrative, just to fulfill my obligations. This is what I want. Okay, it sounds good. Here is your data permit. Then, of course, the data wouldn't be sent to you in your lab and you lose them, whatever. They will be put in the secure processing environment, as Markus said, in anonymized way, certain exceptions there, but the norm is anonymization. You take the algorithm there, you do your research, you get out the data after 6 months. Within 6 months, they should be deleted from the secure processing environment. So as you can see, you are at least finding this data somewhere to be able to also fulfill your obligations. Now, at this day, you might say, okay, there is millions, trillions of data there. How am I going to find my way in all these, even if you're collecting data from the hospitals, for example, from other research centers, and how am I going to find them? I think this is where maybe, again, the European Health Data Space might provide some help. The data holder under Article 41 of the European Health Data Space is obliged to also provide a general description of the data sets that it holds to the health data access body. So I'm a hospital and I'm saying I have, for example, 1,000 MRI images of lungs of that. I have 1,000 breast images on that. So you provide a description. And then the health data access body would create under Article 55 a metadata catalog. So the researcher there could be able to consult the metadata catalog to see what data exists and hence make an application. Then another member state, let's say that's Sweden. Another member state B, Italy, let's say there, creates their own metadata catalog. The metadata catalogs will be sent or become available to the European Commission, the flag there, who is obliged then to create a EU dataset catalog. So you have also, let's say, a catalog of what it exists all over Europe. And that would be the idea, because these are the, again, high-level requirements that they need to be specified. Now, coming back to Article 10 of the AI Act, it also includes, again, this is the data section of the AI Act. That's why I'm focusing on that one, not referring to the others. So coming back to the data section, it also includes the obligation when you are developing an algorithm. It says to examination of possible biases, data preparation, processing operations, labeling, cleaning, enrichment, data collection, suitability of data sets, data gaps, formulation of assumptions, etc. So it has a list of obligations and that you need to think and carry out. Again, I'm just focusing on bias for the sake of the narrative of my lecture, so of my talk. So it kind of not jumping into all over. Let's focus on bias. I think the question could be there again, what is bias? And also, it might become even trickier because the AI Act is a horizontal piece of instrument, which means that it's applicable to all domains, all high-risk domains, including healthcare medical devices. So you might say, how should I be interpreting bias? And again, the answer is that through standardization requests by the Commission to create standards, through common specifications by the Commission. So this is the, let's call it the second stage of work that needs to be done as soon as the Act is adopted, or actually it even started now, the thinking. So now, of course, you might say, okay, if you create these specific data quality requirements in the AI Act, how then do I find my way on the European health data space to help me also in this respect, for example, with regard to bias and understanding the data I can find there to use them and fulfill my obligations here? And here I think, and this is what it might be of use to the developer, is Article 56. The data there, if there is data given to the data access body, they may have, and I will come back to it, a data quality utility label. If, however, the data that are given to the data access body have been the collection and the processing of the data came as a result of member state or EU funding, you are obliged to have a data quality utility label. So if you got funding for the collection and the processing of your data, you are obliged to have a data quality utility label, the law says. Now, what is a data quality and utility label? Again, essential requirements, high-level requirements at this stage. As I said, the second stage would come to specify them. It says the data quality and utility label should include elements like bias. Bias again, you see, it's also mentioned there. Accuracy, uniqueness, enrichment, etc. So again, you may also ask the same question. What do you mean bias now under the European Health Data Space? What standard should you have? Is it a third-party assessment to check bias? Is it a self-assessment? How does it connect to the AI Act and so on? Here, I think one clue we get is, I would say, Article 56.5, which says that the Commission shall set the characteristics, technical specifications of the above, including and taking into account the requirements of Article 10. You have seen, actually, it's intentional that we have put it in there when we're drafting them. So we made the two worlds somehow talk to each other. Of course, let's not forget that the European Health Data Space is not only for AI. So you have creating things which are applicable to many domains. And the same thing, the AI Act is not just for AI in medicine, but some connections there, some common language and some connections between these two worlds. I think, as you can see, you can spot them there. Now, at this point, I think it's also a good place to jump a bit into the Product Liability Directive. Now, these are my own connections. These are not official Commission connections, but I think they match, and you will see why. The Product Liability Directive, which was published, as I said, September 22, and this is the classic, let's say, textbook liability diagram. You have a manufacturer which is creating pharmaceuticals or an AI-based medical device, let's say, and this system or this medicine causes damage. So the first question that it was kind of addressed, the Product Liability Directive is already in existence, but it's amended from the previous version. The first thing, do we need to change the issue about damages? The answer was yes, except, let's say, the classic one, death and personal injury, which is already there. It was also added psychological health, but also something about data, which might be interesting, maybe yes, maybe no. Loss or corruption of data, it says, not used exclusively for professional purposes. So this could be also a compensable damage. Now, the big question, I think, however, is when it comes to deter, because you need to prove the effectiveness of the product and causation. These actually are quite challenging issues. Even for conventional products is challenging. So the question arose for new technologies, including AI, it might be creating even more concerns, more questions there. What is the meaning of defective AI-based medical device? And how could, as an individual patient, be able to really determine, this AI-based system is defective because they have not done at that point this thing. So that was a bit the question. The answer, the mechanism that the Product Liability Directive adopts is through presumptions. It creates basically presumptions concerning the defectiveness and the causation there. And what are these presumptions? Because there is more conditions and so on, but I'm just giving you a flash of some titles, which I think you will get at least a gist, or at least increases your curiosity to read deeper. What are the presumptions of effectiveness? First, it says if you are not complying with mandatory safety requirements. So in my interpretation, now it's personal interpretation, again, it's not Commission found somewhere, but in my interpretation, it could be also safety requirements. So to me, thinking about AI in medicine, I'm thinking about it, the AI Act, which also provides safety requirements of how you develop the AI system. So if you have not complied And as I said, my interpretation is if you have not complied with some of your obligations under the AI Act, then you would be presuming that the product has been defective of what you have created. Of course, at this point, you may also ask, who are me? How am I going to understand now how they have complied with their obligations under the AI Act? The Product Liability Directive also says in Article 8 that the national courts are now empowered to order the defendant, let's say the manufacturer, to disclose relevant evidences. So you have the right to ask now, I want this. Of course, this is just flashes, because it also says, I didn't write it there, so I don't have too much legalistic analysis there, but also is subject to intellectual property rights and trade secrets and so on. So it's not so absolute as it might appear, it's subject to. But that's the idea, so at least it gives you some information how you do it and so on. Then, if you fail to comply with the obligation to submit evidence, then it will be used against you because it will be presumed again that your product has been defective. In a way, you hide something, and that's why you are kind of punished. Of course, you can rebut the presumption in law. It's not absolute the presumption. It's not a reversal of the burden of proof, but it's a presumption which is created. And another thing which I just add there, because it's interesting for my personal research, it says also obvious malfunction. And I think the interesting question there is that when will we consider that an AI system is malfunctioning, and when is it designed defectively, and when is it malfunctioning? So I think that's, of course, I can talk about that thing, but not for this presentation. Now, I think here, if I were to also push to make another link, let's go to the other liability directive, which was published on the same day, the AI liability directive. This is not the products liability directive, the AI liability directive, which is two directives there. The players here are these three. You have a faulty D, a faulty defendant, basically a negligent one who did something negligent. There is an output of an AI system, and there is damage. This directive focuses, among other issues, on this, on the presumption of causal link between the negligence of that one and what the system has produced there. And they create a presumption, a connection, basically, that the cause of the output was the negligence. Let's say if you are accusing someone for negligence of that one. Of course, here you may ask, why should I use this directive and not the product liability directive and bring a legal action against the manufacturer? Actually, in most of the cases, this is what you would do. You will use the other directive. However, maybe in certain situations, you might also use this one. Of course, the D there is not just the manufacturer, it could be also the user. So this one might be used, let's say, against even someone using AI systems in healthcare. So let's say physician. So the scope of the D is a bit wider there.
Yiannos, 2 minutes.
Okay. And one of the conditions there is the non-compliance with the duty of care laid down in union law and blah, blah. And again, it's a flash. You have to read, it's multiple conditions, and you have to fulfill all of them to gain this presumption. But one of them, just to focus a bit, is the duty of care laid down by union law. And again, when I read it, it reminds us, or it should remind us, of the AI Act. And indeed, if you go there to the following paragraph, it says that the conditions in Article 4A1A, of course, there is many conditions that you need to fulfill, but at least this part of the condition, it says, is fulfilled if you failed your data requirements. Actually, expressly, this one, it says, if you failed your data requirements in Articles 10 and 2 to 4 of the AI Act. So as you can see, there is these links, how the different worlds or the different legislative initiatives are talking to each other. And maybe another 1 minute. I had a few more slides, but I wouldn't get into these things. I don't have the time. But I think it's also important. I talked a bit about the other issues now, but to also keep in mind for AI in healthcare, this deployment of AI in clinical setting. Because you have seen, I will just give you a concrete example. In the US, there was research, the same algorithm, working really well in the lab. It was deployed in 2 hospitals, teaching hospital, non-teaching hospital. In the teaching hospital, after the AI system was deployed, death rates dropped. Non-teaching hospital, death rates more. So as you can see how it is deployed, how it is interacting with the physicians, and what happens there, it's also a whole another new story. And my final conclusion here. So as you can see, if we go back just for 5 years, 2017, 2018, we are talking all about all these issues, very theoretical. I think the Commission was quite quick in that sense to come up with a framework. Actually, it took a more bold world step in that sense, because we have at least a framework about AI, the AI Act, a framework about data, the European data space, a framework about liability. And let's not forget the medical devices regulations, which were also implemented last year and the year before, plus core jurisprudence, which might be developed. So we have a great, interesting potential there and framework, which, as I said, is a leading step maybe in the world. At the same time, I think the challenge is to make all these work together, to understand each other, to make them work together, and so on. Thank you.
I think I would like to save the last 5 minutes to some general questions. So, Ricardo,
Okay.
the floor is yours.
Okay, thank you very much. Okay, so now it's my turn. I see my presentation in the screen, not there. Okay, thank you. So good afternoon again to everybody, Mr. Chairman, organizers, colleagues, friends, ladies and gentlemen. Thank you for coming for this session and to listen my presentation. As I said, I'm Ricardo Gonçalves. I'm director of UNINOVA, the research institute from the Faculty of Science and Technology of the Nova University of Lisbon, where I am full professor in there, and I am head of research for the interoperability of complex systems, where data is crucial, interoperability between data is crucial, and quality of data is for sure one of the major challenges. So I've been working in the field for more than 30 years, and that's why for me and for UNINOVA and for my research center and group, this forum is really very much relevant. That's why also we are the premium sponsor for this forum, and we are exactly here to show what we are doing concerning digital health data, but also looking for synergies and collaboration. So I leave already the message that I will be around for today and tomorrow and completely available to talk me and my colleagues that are here to discuss ideas, opportunities related with this topic. Okay, so the main objective of this institute is to pursue scientific research, technical development, high-level training, and the creation of technical innovation centers. So basically, we aim to be the bridge between what is the university, where we develop the basic research, to the institute, where we extend this basic research to applied research, innovation, and then the transfer to the society and to the industry in general. And considering digital health or e-health, we can all agree that indeed today there are a lot of technologies that are available, and these technologies can be indeed put in practice in services to the health sector. We can embrace areas like telemedicine, telehealth, electronic health records, more specific related with data, patient self-care and monitoring, etc., etc. All these technologies are available, and the main challenge now is how we can take the most of these opportunities, and in this case, for the health sector, in order to contribute for a better society, a better well-being in terms of the citizens. And the societal dimension is really very relevant in this point of view and in this mission. The European Commission, during the last few years, especially in these new working programs, Horizon Europe, Digital Europe, and those also related with health, are pushing very much to move the paradigm for a citizen-centered approach. Not look for solution approach, not look for technology-centered approach, but look for what each one of us really can take the most from the technology. And this applies exactly for the health sector, because health for all of us is very important, is crucial, is fundamental. And if we can use this strategy in the willing that we can have better well-being, better health, this can be really a fantastic opportunity. And to support that, there are many areas of applied research, of technologies that can be really fundamental. We have sensors everywhere. So Internet of Things, that we can call Internet of Medical Things, if you want, can be part of this strategy. But we can take the big data that already exists, considering the health sector, and do even better, develop new algorithms, new applications, so etc., etc. All these are part of this support for a better health through the digital. And this is exactly where UNINOVA is focusing among the other areas. So we address industry, we address energy, we address many others, but digital health is now core of our activities. And indeed, now the UNINOVA is in the forefront of innovation in order to look for the modernization in terms of the use of the digital transformation, looking for proposals that can indeed provide a better use of the digital in the different sectors, including the health. And based on that, we are organized in the 6 major pillars, now addressing specifically for the digital health sector, where digital transformation projects are part of the strategy, to have direct contact with the end users, with the citizen, is also part of it. That's why we are here. That's why we are placing different exhibition centers, not just in Lisbon, but also out of the country. Clinical activities, being involved directly in clinical activities, support scientific development and employment. Very much important is the training and education. Digital skills, literacy in digital skills is also part of our strategy, and then also organize community events where we can provide the most in this context. And the main orientation lines for the work that we are doing is absolutely for sure the European Union orientation lines. The European Commission, we have here in the previous speech, clear views and contributions about what are the main guidelines that should be taken into consideration. And what we are doing at UNINOVA is take as a basis these guidelines, take as a basis the opportunities coming from the different calls that we understand are the priorities to deliver outcomes that can bring a better Europe for all of us. We propose such opportunities in order to get also some funding that is very important and contribute for the society in Europe. And with the advent of COVID-19, this become even more relevant. And what I will show you during the next minutes of my speech is exactly what are some of the reference projects that we are developing in digital health that we believe are very much relevant for Europe in general. I select these 4 projects. We have many others, but these are four main projects that are funded by the European Commission. The first one is the Smart for Health, that UNINOVA is the European coordinator that develops a citizen-centered European electronic health record exchange for personalized health. I will explain in detail what is the objective and the solution provided, but aim is to assure that the citizen can have access of its own data anywhere, anytime, everyone can have it. Then we came with ICU for COVID. ICU for COVID is another project that also we are coordinating, and we are establishing a network of apps in Europe of telemedicine, supported by artificial intelligence and sensor, where the aim is to help not the patients, but the healthcare staff. Then we have Smart Bear, is another project where the aim is to provide personalized support for healthy and independent living at home, especially for the elderly people. And then I bring FACE, that is a project I start now going in deep. That for me is a very special one, that with the aim of this project to give support using digital to the people that got cancer. So it's people that are recovering from cancer to develop an application that is based on a federated ecosystem of different specialties, but using the patient as the center and using the digital as the communication platform, supported by artificial intelligence to provide help to the patients after or during the treatment of cancer. This is for me very special because one of the partners wanted to be exactly the pilot, the case study, and it's really a very intensive project that is delivering very relevant results. And for me, it's a very good example of, let's say, a simple concept, a simple idea can really bring better quality of life to all of us. So for those that are Portuguese, this project also counts as a partner. The Champalimo Center, as you know, is a reference center here in Portugal for cancer. This is another project that is also very special because it was applied in the beginning of the pandemic 2 years ago, and the European Commission funded with the aim to establish a network of telemedicine that intends to transform the peripheric intensive care units into efficient cooperative centers to improve the treatment. The aim here is not to support directly the patients. Here is to use telemedicine to support the doctors, to support the nurses during the activities in the intensive care units. And especially when you have regions where you have a central hospital and many peripheral hospitals where the doctors cannot be everywhere at the same time, this became really a very important project. Also supported by the network where all over the Europe, we can really deploy this telemedicine, and using a specific cockpit, we can communicate, or the doctors and the nurses can communicate depending on the cases they need to take decisions. In Portugal, we have 3 main centers. We are all over Europe. We have in Germany, we have in Italy, we have in Greece, Romania, etc., etc. In Portugal, we have in Lisbon, we have in Madeira Island, and we have in Azores Islands. Islands are very important because, as you can imagine, we don't have principal hospitals in all the islands. And this enables the avoidance to transport patients when they are in need, when telemedicine can help in this support. I have here a video where illustrates the mission of this project. If you can put the sound, please. Can I start? That's myself. Okay, so this is a clear example of the use of the digital technology can really help, in this case, the healthcare staff in the daily activities in intensive care units, using also collaborative platform in a network of apps all over, in this case, Europe. Another project I bring here that I think is also very, very important is the Smart Bear. Smart Bear means smart big data platform to offer evidence-based personalized support for healthy and independent living at home. In short, this means to use the digital to support those that are at home, especially the elderly people that are not so used to use the digital technology, but that technology can be really very much relevant. So the target diseases for this project are cardiovascular diseases, mood disorders, balance disorders, frailty, cognitive disorder, hearing loss. These are those 6 that were selected. But in general, the main objective is to reduce the morbidity and to improve the quality of life through active prevention, support at home, put all the technology that is available in the service of these citizens that have such need and they cannot leave home. So basically for the pilot, we are using 6 countries. It's a 5 years project and is involving 5 million European citizens in the demonstration. And amazingly, we are getting really, after a first reaction from them in the use of the technology, because most of them are not so used to use these digital technologies. Now they are more and more used, and this really become a big difference. In terms of digital and how this relates with the data, because data is the core of all the functioning of the system. So we have a sensor ecosystem that is the data acquisition from those that are in need. And then we have data analytics that are provided in order to identify medical conditions, what are the risk factors, and then supporting for the intervention. And many devices are in use, and also for sure here, data and data quality is fundamental. I did not mention this for the project on telemedicine, but as you can imagine, if the data has not quality, so the network is useless or even can be very dangerous. So the assure of this pilot, this quality is very important. All these projects does not work alone, so there are several synergies with many others in order to take the advantage. So the aim here is not to invent or create new technologies, is to use what is already available and put it in the service of specific objectives. Another one is the Smart for Health. Smart for Health has a major dream that was to enable the citizen to have the data accessed anywhere from where it is stored. I mean, this is a project that is connected between Europe and also United States. So the Mount Sinai Hospital is part also of this consortium. And the aim is exactly to enable every citizen to access the data easily, securely, anytime, anywhere, by everyone. This aims that the paradigm of the citizen-centered here intends to be implemented. The aim is to move from the direction where the data is spread and stored in different sources, different hospitals, different health centers, and using interoperability to allow that all these data can be accessed by the citizen using the mobile phone, of course, under the rules of GDPR, ethics, privacy, etc. And with that, it means that the sources of the data can be available in electronic health record systems. For example, we have the regional health system in Portugal from Madeira region already ingested in this platform. We have also tourists that are visiting the region, also ingesting data there, and sensors coming from the projects that I mentioned, also enriching the source of data. And with that, using the citizen health data platform, using the mobile, the citizen can manage his own data. For example, to give it or show it to a medical doctor, or for example, to give it for research if he wants it. So all these things are a possibility, and the aim here is to contribute with fresh ideas and proposals for unified electronic health data in Europe.
Ricardo, 2 minutes.
Okay, good. So testing and validation framework. So we have 8 citizens and use cases. And this is a video that describes the aim of the project.
Share her X-ray pictures with her doctor. How could she do that? Nina has been using the Smart for Health application to track her progress in her back pain therapy for a while. She can also use the application to share her medical information with healthcare professionals, relatives,
her mobile phone or computer and upload her documents. Nina wants to share her documents with her physician, Dr. Samari. She starts a sharing session. Then she calls Dr. Samari and explains to him that he needs to verify himself to get access to Nina's medical information. Dr. Samari visits app.smartforhealth.eu/share to access the PIN and tells Nina the PIN. She approves the sharing session. Once the session is established, he can easily view and download the shared documents. After Dr. Samari closes the session, his access is automatically revoked. Nina and Dr. Samari are happy with the solution. For Nina, it offers an easy way to securely store and manage her medical and health-related data. It is easy to share information even when she is not in the doctor's office. Dr. Samari benefits from the fast access to well-structured information and can spend the time with real patient care.
This is another example of the projects that we are ongoing. And as a final slide and as a strategy that we have in the Institute is to contribute for the path for digital transformation in health and well-being. So to look for faster diagnostics, better collaboration, look for innovation, and also sharing in terms of data and information. And very much important is the digital literacy, the literacy in the digital. And exactly to respond to that, we applied to the digital skills program. And now we got a project that will develop an international master in digital health. And this international master is not focused for the young students, those that are coming on the 20s and just doing the first master, is looking forward to those that are already working and they intend to get skills in digital to take more advantage and profit from the digital technology. And based on that, and aiming also to contribute for the society, we are working close to the society. And for example, in Madeira Island, that is a place where you have lots of tourists, you have people coming from all over the world. We have a stand with all these technologies available and where anyone can go there, test, validate, even do some kind of activities to get the feeling and hands-on on the results that we are getting. And I close my presentation with a video that also describes this initiative. Okay, so thank you very much. I'd like just to inform, we have a stand outside, so if you'd like to have more information, even we have some technologies in there, so we are very happy. I have here two colleagues, Maria Marques and Carlos Agostinho. They are there seated. Say hello, please. So they will be also moderating a session after, and tomorrow we have a presentation that goes in deep on the Smart Bear and Smart for Health project. So if you are interested, I really encourage you to attend. Any question, please contact me.
Thank you. Yes, we have. We extend the session for 5 minutes because we have some. We have I think a Zoom question to Yiannos. So
you need to speak to the mic, Mats, otherwise Zoom does not.
Right. So yeah. So there is one question that was posed during Yiannos' presentation. So Paul, will you take
So
that?
the question is, and then we also have a question for Dr. Ricardo. Is there an emerging standard for metadata catalog in healthcare or outside? So an emerging standard for metadata and catalog.
For me?
No, Yiannos.
What is the question? Emerging data?
If there's an emerging trend
Yeah.
for a metadata catalog
Uh-huh.
in healthcare or outside healthcare also.
Of course, as I explained, under the European health data space, there would be a metadata catalog obligation. the data holders would be informing what data they hold, and then the European Commission will also create, we can also call it a metadata catalog of what exists in the whole of Europe. So at least under the European Health Data Space, yes, those obligations would be there. Yeah, for metadata catalogs.
A question for Dr. Ricardo, if I may, Matt?
Yeah.
So Ricardo, which digital skills are you addressing? ICT skills or more specific skills? Targeted at health professionals or in general for all professions?
Well, the target is, of course, all professionals. The application domain, in this case, that's why the main scope of the master that is funded now is the health sector. So in short, I can say that the target is mostly for those that are in the health sector and would like to get further insights in the digital technology. And digital technology here is the transversal way that we can see the digital technology. Could be the electronics, could be the user interfaces, could be the algorithms, could be the concepts. So all these aspects are to be addressed. I can mention that this is an international master, so there are several universities from Europe participating, Portugal, France, Germany, Spain. So mostly all Europe is involved. It's organized in modules, and the students can enroll in each semester in different modules in order to take the most of it is, let's say, of the interest of the student. This is presential, but also technology enhanced learning applied. So remotely they can participate in the course. And out of Europe, we have also the Israel participating. So Tel Aviv University is also involved, especially not just in the area of the technologies for medicine, but also in cybersecurity. That, as we all know, they are really #1 in the world.
Thank you. So do we have any other questions from the auditorium?
Hi, my name is Regina Hill. I'm the CCO for Wales. I'll have a presentation where you have a video demonstrating the future. I'm just surprised that we're suggesting that patients can have plain imaging loaded on their phone, given that the majority of imaging will be large volume data, CTs, MRIs, and is it not creating expectations that individuals will not be able to meet because the data storage won't be there?
No, probably the message was not correct from the video. No, the data is not downloaded. It's just accessible and can be transferable. If you want, you can download it, but you don't have the data in your mobile. You have access to the data through the mobile. So this is the message. Otherwise, I would agree with you. It will not be practical to have such amount of data with ourselves.
All right. So I know that coffee is just around the corner, but I have a closing remark. And so given the emerging data quality areas that we have before us, I would like Markus and Yiannos and Ricardo to have one takeaway sentence. I know it's hard, but try. What you think is important that is awaiting us around the corner, which have relevance to data quality. Just one sentence. Is it tough?
Yes, but okay, I can
give it a try.
Yes, I think that for me, and based on what is my vision on this respect, is crucial the transfer of the technology to the society, to the citizen. And without the demonstration of the quality of the data, we cannot build the trust in order to motivate more and more a better use of the digital for each one of us.
Thank you. Yiannos?
Maybe I will start with my first slide, which was showing that the abundance of data plus AI would be transforming healthcare. And I think we need to see that soon. We have been talking about it for the last few years. I think there is a lot of research, but I think we should see the patient reaping the benefits of this revolution. We haven't seen it, I think, fully scaled yet. We need to see it, and we have to all work to see the concrete results of that.
More evidence. Then.
More evidence, more go to a hospital and really see AI and really seeing something revolutionized. I think we need to move quickly to that.
Thank you. And Markus?
I tried to answer with one sentence. So with the European health data space, EU takes a giant leap forward in data quality.
Thank you. And there is nothing that can hinder you to take coffee. So thank you very much for all the speakers and the questions. And
Thank you so much, Mats, for this moderation. Just to remind the guest speakers, you have a speakers lounge, so you can go there for your coffees.
Very interesting.
And entertain conversations that you like with other guest speakers and summit members. The speakers lounge is in the first floor med seats. There are signs there. The participants can take coffee with the tickets, and we'll do a final reminder for the bus to the dinner in the next plenary, which will be the last one. Enjoy your coffee break. And thank you so much, Zoom participants, for watching, and also our live viewers in social media, YouTube and LinkedIn. It's great to be here and having your presence, virtual presence with us. Thank you so much.
Card, but I have when I was